fluid situation that changes rapidly. I used to say it changes day by day, but sometimes it's changing minute by minute. What was true yesterday is obsolete today in some situations. At Essentia Health, we've been working tirelessly to prepare for this challenge. Our top priority is the safety and well-being of our patients, staff, and the communities we are privileged to serve. Consequently, we have implemented several policy changes of late. These include the temporary discontinuation of elective procedures and routine appointments, which will allow us to make the most effective and efficient use of our limited resources. Visitor restrictions aimed at preventing the spread of the virus. These were not easy decisions to make. No healthcare system wants to restrict access and delay care. But we truly believe they are in the best interest of our staff as well as the community at large. At Essentia, we have launched free e-visits for COVID-19 patients. We had over 300 of them just yesterday. This is the best way for us to screen patients and determine if additional treatment is required. You can also call our but there's a lot of information on the hotline. There has been much debate over the past couple of days regarding the accessibility of testing. Nationwide, there is a shortage of testing supplies. This is forcing us to be judicious with our tests. That's why it's important for patients to begin with an e-visit or call our hotline. This will allow schedulers to screen for key symptoms, which include shortness of breath, fever, and cough, along with known exposure to COVID-19 and or travel to an affected area. In accordance with the Minnesota Department of Health guidelines, we're only conducting outpatient tests for symptomatic first responders and healthcare workers with direct patient contact. We can also test people who are hospitalized and suspected to have COVID-19 and those who are symptomatic in groups such as nursing homes or long-term care facilities. We do want to emphasize, however, that if your symptoms are severe and you need to be seen by a doctor, call us if it's not an emergency. We're going to get you in and we will care for you. Obviously, if it's life-threatening emergency, call 911. It's crucial, really crucial, that people don't panic. But we want you to be cautious. If you can stay home, please stay home. I feel like repeating it just like that phone number. If you can stay home, please stay home. If you must go out, limit your interactions to groups of 10 people or less. You've no doubt heard the term social distancing. This virus is spread primarily by respiratory droplets, which can travel up to 6 feet. So we advise you to maintain 6 feet of separation from others, like Dr. Van Dielen and myself are doing right now, at least 6 feet. We also advise you to wash your hands often, cover your coughs and sneezes with tissue or into your elbow, wash your hands frequently, especially after you've touched some surfaces, and you're supposed to do that for 20 seconds. And as I said before, that's singing happy birthday silently or out loud twice. And avoid touching your face, which I know is difficult to do. We all habitually do that, but when you do touch your face, ask yourself, why did I just touch my face? And find out what those trigger symptoms are that forced you to do it, and think about that and try to adjust accordingly. And perhaps just as importantly, be patient and compassionate. There's no playbook for navigating this particular pandemic. We're all learning as we go. We are all in this together, and we're going to get through this together. Thank you.
Thanks, John. I'm Nick Van Dielen. I'm Chief Medical Officer from St. Luke's. I'd like to echo what Dr. Pryor said earlier. It has been really something to be a part of, the level of collaboration between Essentia and St. Luke's. And I want to, again, reinforce that so you know that our institutions are working together. Many of the things that John has spoke to, we both have adopted, and it's an attempt to be clear, to standardize our message so there's no confusion. We know that this is a time where there is a lot of confusion. One thing I specifically want to address is the social distancing, and this is especially important as people are returning from travel elsewhere. And in this, I'm speaking to a lot of young people who may think that this illness really doesn't matter to them. Partly we know that as this disease progresses, and although there are no cases locally yet, this disease will come to our region. Many young people will have absolutely minimal, if no, symptoms, and they won't know if they're passing it on. So we ask everyone to practice social distancing. Stay home, enjoy walks outside, keep yourself 6 feet away from the person next to you, avoid gathering in groups greater than 10. I think the other thing I would like to reflect, and I'm sure Dr. Pryor would agree, we've been overwhelmed by the support of our community. The media has done a great job of trying to help get a reliable, accurate message out. We're consistently getting well wishes from those of you in our region, and we greatly appreciate that. We crave the support. We're not surprised by it. We do feel really honored to be serving our region. St. Luke's, through our Incident Command Center, continues to work towards finalizing preparations, and those are detailed preparations that look at a tiered response depending upon how the pandemic does proceed in our region. You can rest assured that these preparations are well along, and that no matter what this pandemic brings to our area, both St. Luke's and Essentia are prepared to care for you and your family. Dr. Pryor alluded to the difficulties with personal protective gear. This is in regards to gowns and gloves and masks, and they are unfortunately in short supply. We're working together and really trying to access sources that we can throughout the region to try and make sure that our patients and our staff are protected. In regards to the testing, again, and I know you'll feel like this is repetition, but sometimes that's necessary. Because of the lack of some of the equipment necessary to screen people, again, we want to reiterate, people who should be screened are healthcare workers or first responders who are symptomatic, people who are admitted or being considered for admission, or symptomatic patients who live in a congregate setting, like a nursing home, like a group home. I think the other thing to share is just at St. Luke's, as we prepare, and I'm sure Dr. Pryor would agree, there's significant disruption and change. As we have canceled our elective procedures, and as we see our clinic volumes diminish as we move patients with routine visits, we try to move them more towards either postponed or telehealth visits. Our staff is feeling disruption, but it's just so gratifying to see the offers of help for each other, the willingness to move to different areas, and we greatly appreciate all the work being done on behalf of our patients by our staffs. This is a constantly evolving situation. We try to be mindful of the important information and try to communicate that to you. A really good access point for the public who has access is to use our internet webpage. We do have a nurse hotline as well. You can access that at 218-249-4200. That's 218-249-4200. And again, that's a nurse-managed call line to try and help people walk through their questions in regards to should you seek evaluation, should you not. The main message there being, if you are healthy, you don't need to seek evaluation for this. Even if you have a fever and cough, you should stay home, you should stay away from others, you should self-isolate. Again, thanks for your attention, thanks for the opportunity, and we look forward to continued efforts together to share as things evolve.
Be happy to answer any questions, and we've got two infectious disease specialists, Dr. Thompson from St. Luke's and Dr. Prabhu from Essentia, that's here also. They know a lot more about COVID-19 than Dr. Van Dielen and I do.
Yeah, Dr. Prabhu, if you want to come here.
Just stay 6 feet away, okay?
Yeah. Questions?
Are there enough hospital beds?
Right now, yes. There's enough hospital beds.
And so just to address that, that's part of what we do as part of the incident command is to look at contingency planning. So there are absolutely enough hospital beds now, but we're planning for what happens in a month, what happens in 2 months. So there are very detailed plans going forward, again, no matter what volume of patients are brought to our hospitals.
Can you give us any idea of what those plans look like? I mean, are you talking to other facilities in town, rehab clinics, making space available there potentially? And can you give us any idea what some of these contingency plans are for beds?
Sure, I think we can probably all answer some of those. So we're sharing data with Minnesota Department of Health and the Minnesota Hospital Association on our bed capacity, particularly in the ICUs and on our ventilator capacity. We're looking at ventilators within the operating rooms, which you have to put a filter in there to use them long-term in an ICU setting, but we're looking at that as a possible supply for ventilators. We're looking at other sites out in the community that may not be as busy where we can transfer some of our less acute patients to open up beds at the more acute hospitals like St. Luke's and Essentia to take care of the sicker patients. Definitely there's an attitude of sharing resources amongst all the health systems as needed. And I don't know, Dr. Prabhu, Thompson, Van Dielen, what other things did I miss?
Yeah, I think it's important to know that there is a regional coalition for healthcare that they've opened their Emergency Operations Command. They help with coordination across facilities throughout the Northland. I think I would, again, echo what Dr. Pryor is saying. We are looking at areas within our facility, within our network, that we can repurpose to expand our critical care capabilities and space, to expand our space for patients. We are talking to our partners in the community, long-term care facilities, group homes, also talking regularly with Lee Stewart and the folks at CHUM, trying to think about what kind of facility do we need to be developing so that all of our citizens have a place to be cared for. So I can't give you the details, but I can tell you they are very detailed.
You guys have said that you are prepared for this, but you have both admitted you don't have enough protective equipment and you don't have enough tests. So how can you possibly prepare for something if you don't know how many people in our community have this or will get it?
I can answer that. So I guess first point is amount of equipment. At the moment, we do have enough personal protective equipment. We do have. So this is, I guess you look at it this way. Since this is the viral respiratory season, we do use the same types of equipment for a variety of virus infections. So influenza, the same things that we would use for COVID-19 is that. So that's one of the reasons. So we do get constant supplies of so if someone were to come in today, we have enough personal protective equipment. Contingency plans, face protection. We use N95 respirators or surgical masks. So there's contingency plans to reuse the N95 respirator. Typically, because it's a once use and dispose of. But those can be safely used for a prolonged period of time, for a whole day. So a contingency, say, if a lot of people get admitted to hospital for COVID-19, we would use that same mask. So that was one way that we would preserve personal protective equipment. We have enough gowns. That's a standard thing, the yellow gown. If anyone's been to the hospital, you've seen providers use the yellow gowns. We do have that. We do have gloves. And I want to comment on, in terms of the capacity of our hospital. So there's contingency plans for that. So meaning not every patient that's admitted to the hospital with COVID-19 will need ICU care. They will need regular medical floor care. So that's one of the reasons you see all health systems canceling elective surgeries. And what that does, it gives us capacity, hospital beds, to provide for patients that need that care if it's COVID-19. So we have outpatient centers, at Miller Dwan, the day surgeries, all those beds could be repurposed to caring for someone with COVID-19. In terms of ventilators, obviously, without COVID-19, we still have people that need ICU care. So we do keep track of the number of ventilators available, and we will be creative, meaning if you don't do surgeries, patients that go into the operating room, most of them have to be on a ventilator. So that's sort of a creative approach to how do we manage a surge. So those are just some of those examples.
And if I could just reiterate in regards to PPE, so all of the procedures that we do consumes PPE, okay, personal protective gear. That's a big part of the reason why we've moved away from elective procedures, so that we can conserve those resources as we know that we will get to some sort of a surge. We don't know what it'll be, but we have to plan for all eventualities. We have the PPE for daily operations, even in this era of high respiratory illness, but we need to plan for the future. I guess maybe I was a bit confusing with how I presented that.
If other hospitals in the region reach capacity first, are you planning for any patients being sent from Minneapolis or Fargo or elsewhere?
I would say that we are in a community of health systems, and just like we're collaborating, we will collaborate with the metro hospitals and do what we need to do to protect the citizens of Minnesota and take care of them. So I know that the CEOs of many of these major health systems are on calls daily, and they're very collaborative. And so the answer is yes, we will help them if the need be.
Are you guys changing anything within the hospitals right now in terms of getting certain wings set up, or I know you all have your own ICU units, but
So we've done a fair amount of changing our daily operation now. There are certain wings that we change the airflow in to make it a unit just for people with respiratory illness and people who are being ruled out for COVID-19. We're opening up certain areas in anticipation that this may become sort of an ICU level care in case it's needed. So moving, some surgery patients to a different area of the hospital to open up more space for a potential ICU level care.
do you guys have plans in place for when and if a healthcare worker, there's a lot of concern on healthcare workers about if they get COVID-19 and then beyond the normal, what we tell our people is stay home, work days and don't talk to anyone. Is there anything else that you guys are going to do about your healthcare workers or for your healthcare workers?
So the contingents at the moment, so if a healthcare worker was suspected of COVID-19 or diagnosed, the first response would be stay home and recover. And the standard sort of mantra from the health department, CDC, is stay home at least 7 days and at least 72 hours without fever, so whatever's longer. So if your fever is only there for the first day, 7 days, and your symptoms are better, you can return to work, and will most likely have them wear a face mask maybe for the total 14 days. Because no one quite knows the duration of how, when does the contagiousness sort of end. In terms of, what was the other question on that?
I think that
So I guess in terms of plans for during Ebola time, everyone remembers that St. Mary's did have a contingency where we redid rooms that would be negative airflow. So we have a unit in the hospital for that very purpose. And remember that those are airborne isolation rooms, and we keep track of how many are available. But not every patient that gets admitted for COVID-19 needs an airborne isolation room, based on what we understand on the transmission. So if there's someone that's at risk for, quote, airborne related stuff, we call those airborne, generating procedures. If they need to be intubated, put on a breathing machine, if they need to have a bronchoscopy, if they need to get deep suctioning, those sort of things, we would take the appropriate sort of personal protective equipment for those situations.
Dr. Pryor, you mentioned earlier the number of screenings you folks did yesterday. I'd be interested in data from both hospitals, if you can share them on the number of tests you conducted so far and the number of results you got back so far.
So the number of tests so far as of today is 213, but that's across all our markets. You know, there's East Market, Duluth, Fargo, and Brainerd. Within the East Market, this region is in the 90s range, but that changes daily.
And the number back?
The number back, I don't have that. The issue with that is we are now planning to send samples to a commercial reference laboratory, our usual channels. Before, it was the Minnesota Department of Health. And from their guidance, because this is related to the shortage of supplies, test kits. So it's not just our health department, it's nationwide, it's even in the reference laboratories that there's a shortage. So that's why we're prioritizing who we're testing. And that could change next week. If the supplies of test kits come up, they may loosen, you know, who we should test. But the measures that we're taking in terms of if we suspect someone has COVID-19 and they're healthy and there's no plans to admit them to the hospital, they can go home, stay quarantined. And certainly if things change, they get sicker, we will reevaluate them and do the test, because that would change the management if they have to be hospitalized.
Dr. Van Dalen, Dr. Downson, do you have numbers?
St. Luke's has done around 100. I don't have the exact number. Not all of them are back. I thought I last saw in the 50s was the number that we had results on, and all have been negative to this point.
Also for Essentia, all negative to this point?
All negative in this area.
In this area?
Yeah.
Okay, all right. We saw what looked like a drive-through testing station at Essentia West, I believe it was. Can you confirm that and talk about what you're doing in both hospitals as far as
Do you want to go up?
drive-throughs?
Sure.
So before yesterday, we were planning to open a what we were calling a curbside testing center, only for people who met appropriate criteria. So having significant symptoms or risk factors that would make it more likely that they would have the disease. And then yesterday, we were made aware that there was really limited testing from the Minnesota Department of Health, and that they wouldn't be able to perform the tests, and even were somewhat backlogged in their testing. And at that point, we put that testing program sort of on the shelf, but we would be ready to resume if testing becomes more widely available. I think testing will help us protect our community, our healthcare workers. It won't really change the treatment for most people, because the treatment still is stay home and recover. But it would certainly help us prevent transmission. So it's still a high priority to get more testing available.
I'm sorry. Dr. Bradford, did you comment on that?
So as you know, plans change daily, so we were prepared. So the previous standard, the goal was we're going to test everybody that had symptoms compatible with COVID-19, meaning the fever, the cough, the shortness of breath, travel history. But given the capacity issues of testing, we've had to pull those plans back. We will still use those because there are still healthcare workers, first responders that need to be tested, and certainly we can use that area to test them.
So is that what we were seeing in West Duluth?
Yes.
Could you give a sense of any contingency plans in terms of staffing? And, you know, what happens if there's a surge? You have a bunch of nurses or docs who get infected. I mean, hypothetically, if you don't have enough staff to come to work, I mean, I'm sure you've been thinking a lot about this, and I know there's lots of details, but can you give us a sense of how you would deal with something like that?
And
Yeah.
can you also talk about how, if you have enough staff to cover this as well?
Enough what?
Enough staff.
Well, I think this is our first pandemic. I would say that. So that's all part of the contingency plans that you hear from both of us. As our elective surgeries and routine visits are curtailed, those staff will be repurposed to help with patient care roles as their training allows. And the staff have been very interested in how can they serve, how can they help. So yes, we do have a plan that is tied to our tiered approach as the disease kind of manifests itself in our region. Will we have enough staff? We hope so. Again, this gets back at what we've all been trying to really reinforce is what's more important right now is the public health measures. The basic personal hygiene stuff and the social distancing and the self-isolation, because that allows us to, as I'm sure you've heard, flatten the curve. So if we all can work at that, yes, we will have adequate staff.
I would like to point out, first of all, I want to echo exactly what Dr. Van Dielen said. So it's that redeployment which is going to be key here, which is why it's so important that we don't do elective surgery and why clinic visits that are not essential we stop doing so that we have the capacity to redeploy people. The other thing that I would like to say is this is actually a shining example of how the community pulls together because, you know, the schools are canceled. There's need to, you know, take care of the kids during the day, and the community through the YMCA and other sources, they're trying to get pull together people to take care of the children of our staff so that they can come to work. And I'm just really pleased to be involved in such a community that's doing that. So thank you all.
From what I'm hearing from the numbers, you've tested around 200 people in Duluth, which is a city of 85,000 people. Is that really, from the supplies that you have, the best you can do? And do you feel that's adequate?
That is the best we can do. That is not adequate. But it doesn't have anything to do with our capacity. It has to do with our ability to get the supplies to do the testing and with the testing facilities' ability to get the supplies to do the testing on their end.
How do you think it should make people in the community feel that, I mean, I don't even know what the percentage of that is, but it's real small of people who can get tested. And people who can't get tested include teachers who are providing daycare for your staff and childcare people who are providing daycare for your staff cannot get tested, and they're interacting every day with kids who are at home with your staff.
I would point out that the people that we are testing are the people most likely to be positive. So someone who has a cough and a fever and has maybe traveled to an area where there's a risk of contracting COVID-19, those are the people we have been testing. So they're the most likely ones to be positive. If they were to become positive, we could be concerned about wider spread in our community, but they would be sort of the sentinel case in our region. We need more testing, but those would be the ones we have tested would be the ones we really want to know about.
Are you concerned that it's giving people a false sense of security? I mean, I said this at the last press conference, but we get up there every night and say no confirmed cases in the Northland, and people hear that and think, oh great, it's all good. But then when we tell them only 200 people have been tested, you know, I mean, are you concerned that people are feeling safe when in fact there very well likely could be cases of this in our community and we have no idea?
So I can sort of take a stab at that. So the criteria for testing, those are guidelines. You know, there's judgment. It's not an absolute thing that if you're not on the list of qualified people for testing, you can't get it done. I think one of the reasons they focused on healthcare workers, first responders, is they mainly have to go to work to care for people that are sick in the hospital or served for community emergencies. So whether you're tested or not, say as a community member, you're not going back to work, or what your daily activities. You have to quarantine at home. And like I said, this is a situation that changes daily. When the capacity increases, then there will be liberalization of testing. But it won't change the management or the safety of the patient, meaning even if someone came in to the doctor's office and had symptoms, they had a fever and cough, and there's a clinical decision being made, meaning I think you're well enough to go home, you're going to go home. So whether you had influenza or COVID-19, the recommendation is not to go out for your day job and infect others. So in terms of, people want to know, okay, is it spreading in our community? So we are testing a group of people that are at risk. And this criteria that's done is from the health department level. Our reference laboratories do have more liberal testing, but CDC's criteria is the risk factors: travel, known exposure to someone with COVID-19 or a suspected case, and the symptoms. So there is ability to test other people. That's our guidance at the moment.
Let me just add, I just want to add a little bit of another perspective maybe to this. Is there a false sense of security out there? I think the answer to that is yes. So all you have to do, I think it was in the Star Tribune this morning, there's a picture of in the beaches in Florida. We're just packed with young people who are just kind of oblivious to the fact that that there's a contagion out there that they could get and pass on to others. So as a surgeon, we pretend that all the patients that we operate on have HIV, and that we take what's called universal precautions, even though 99% of them plus do not have it. We just assume that. And so I think that each and every one in the community should really just kind of think of it that any one of you could have COVID-19. Hence, why I'm going to stay 6 feet away from you, and hence why we need to hunker down. So I think it's that kind of messaging that we need to get out there so that people people understand the severity of this disease. We can flatten the curve and get over this much faster. So I would say, yes, there is a false sense of security, and it is false.
One more question.
Is everyone still reporting to work as scheduled, or is there a thought maybe some people should stay home and rest up in case they need to be called in and work like 100 hours in a row or something?
So right now, people are reporting to work. As I said before, we've decreased elective surgery and non-essential clinic visits, so we do have capacity. We are thinking on how to, we're going through right now thinking about how we have people rest, as you say, and build up resiliency or redeploy them, or what we're going to do for when a potential surge happens. So we're kind of in the planning stages for that. I would like to say, though, how impressed I am with the employees at Essentia, and I'm sure it's the same at St. Luke's, how hard they're working, how selfless they are, how in some cases courageous they are, because this is scary stuff. I just want to be right out there. This is scary stuff. And yet they're working hard to take care of our patients, the potential patients that might be coming in, and for the health of the community. So when I see what they're doing day in and day out, I just want you to know that I'm personally inspired.
Do you think it's likely there's a case out here and we just haven't tested for it yet in the North?
I think it's certainly possible. Again, we know that the vast majority of people with this illness will be minimally symptomatic. It'll be like you have a cold. Again, I think we have to be careful about focusing on that because we won't know. And back to the testing, we have, both facilities have really dedicated people spending a great deal of time trying to get a hold of an avenue to get tests done. This is not unique to the Duluth area. This is across the country. So yes, I think the important thing is to assume that we have cases, assume that they're asymptomatic, assume it's the group of people that you were going to go bowling with, and then don't go bowling.
Really quick, how long is it taking you guys to get results from tests? Because we heard a couple days ago it's 5 to 7 days to get results back. So it's totally possible people you tested 5 days ago are positive and we still don't know, right?
I think, so the state lab is still in the average of 3 to 5 days. One of the other reference lab in the state We heard this morning they think they can shrink that to a 2-day turnaround.
So, I guess 2 points. So, yeah, the turnaround time was, say, 5 to 7 days in the Ministry of Department of Health, and that's why they had to regroup and say, who do we need to prioritize to test? So, if we prioritize who we test, the capacity of the lab at the health department will be better, so the turnaround will be improved. And plus, we do have commercial laboratory reference labs, which should be at the moment to have a turnaround faster. And in terms of the question, I kind of forgot this point, is we will know when someone has COVID-19 in the community, because what are people concerned about? They're not concerned about a minor respiratory illness that goes away in a couple of days. They're concerned about a severe outcome. So anyone that comes to the hospital with a severe illness, we will test for COVID-19.
You really think that's true? People aren't
No, it is true. No, clarify. If you are admitted to the hospital, and we do our job to evaluate if you have a respiratory illness, fever, cough, shortness of breath, you're put on a ventilator, you're ill, and we suspect a respiratory infection, we will first evaluate you for whatever respiratory infections that are circulating in the community, and they do get a COVID-19 test. That is one of the priorities. Hospitalized patients, healthcare workers that are sick but not sick enough to be hospitalized, people that live in congregate settings, nursing home patients, group homes. So the canary will be, in the room, will be the hospitalized patient that has a severe case. And as Dr. Pryor rated, we presume if you come into the office or we have an e-visit and you have a respiratory illness, but we determine by just talking to each other that you want to just stay home. It doesn't sound like you need to come to the doctor's visit. We're going to presume you have COVID-19. We're going to do the same measures. You have to stay home till you're well. And any member of the family that's in that household, the recommendation from the Minnesota Department of Health, they also have to limit their interactions with the community. And when testing capacity improves, if everyone wants to know for sure if they have it or not, that we will certainly make that available.
All right, that's going to wrap it up for now. And like I said, I think these gentlemen will stick around for a little bit. We have the room until 12:30, so if you guys want to pull aside or to do some one-on-ones, we're certainly willing to do that. I think moving forward, we'll try to do these every week, once a week, probably at the same time next week. I know both hospitals are kind of getting inundated with media requests, so I think this might be the best way for us to communicate with reporters. We'll certainly try and do our best to respond to those individual requests, but I think moving forward, this will probably be the best format. So, thanks again for coming, and if you want to grab some of the gentlemen. Nice job.
Oh, good.
You guys.
And you too.
Is there water in there? Is there water in there?
Here you go.
Can I just ask how much tests are being
How much will it cost?
This one in there.
In the air, I like it.
So how far apart are we? Do we know?
Oh, we're
Probably not far enough,
but
No one measured it? It's got to be more than 6 feet. It looks big. So, can I ask you a couple of questions? Sure.
That information should be available.
This must be so frustrating for you as an infectious disease, let alone health professionals, to not be able to test